I'm not quite sure what's going on around here. I'm supposed to be teaching a CME session at Maplewood's old Gladstone fire station. I've double-checked the address a few times, so I'm pretty sure I'm in the right place, but to be honest, this isn't quite what I expected. So let's go check this out. Well, this doesn't quite look like the classroom I remember, and I don't see any other EMS providers in here, but I did recall seeing something that vaguely resembled Dr. Frasconi. So anyways, I've got 3 topics burning a hole in my brain, and we got to just get this over with. So I'm Dr. Peterson, and here's the 3 things you need to know. So let's just say that it might start getting cold around here. I know, but let's just say. Through the wonders of modern science and fire, most of us tend to stay plenty warm. But when science fails us or common sense doesn't prevail, carbon monoxide can become a real threat. Now, to make sure we're all on the same page, let's watch this quick video to explain some of the facts behind carbon monoxide poisoning. Check this out.
Carbon monoxide poisoning is a very scary thing, because unless you have a detector in your house, you would never know it's around. It has no smell and no color, and as little as 0.32% of air concentration is enough to kill you. Before we get started, if you're unsure of the difference between carbon dioxide and carbon monoxide, it's the number of oxygen atoms bound to the carbon. Carbon dioxide contains 2 oxygen atoms while carbon monoxide only has 1. When you inhale, oxygen moves down your trachea into your lungs and into small sacs called alveoli. Blood flows around the alveoli in very small vessels called capillaries. These blood vessels are 5 to 10 micrometers thick, and for comparison, a human hair is 5 times thicker than a capillary. Oxygen molecules flow from the alveoli into the blood vessels. Red blood cells then pick up the oxygen by binding them to a protein called hemoglobin. In total, 4 oxygens bind to 1 hemoglobin protein. Your red blood cells then flow through the rest of your body and release the oxygen into your tissue to generate energy. And here's how carbon monoxide disrupts this system. Once inhaled, the carbon monoxide fills your lungs, diffuses through your capillaries, and binds to the hemoglobin protein. But it doesn't just bind, it binds 230 times stronger than oxygen, meaning it never comes off. Only 2 carbon monoxide molecules can bind to the hemoglobin protein, so there is room for 2 other oxygen molecules. However, once the carbon monoxide molecules bind to the hemoglobin, it changes its shape, making the other 2 oxygen molecules permanently bound. So the red blood cell never releases the oxygen or carbon monoxide molecules, and as a result, tissues become hypoxic and the body begins to starve of oxygen. At 0.01% carbon monoxide concentration in the air, the first symptom is onset of a mild headache due to lower oxygen levels in the brain. At 0.08% concentration, severe headache, dizziness, and minor muscular convulsions become more prominent. Convulsions are caused by muscles running low on oxygen. By 0.16% air concentration, fatigue, dizziness, and convulsions become more severe. The individual's heart rate increases because the body is so low on oxygen that it tries to compensate by pumping more blood to the brain and organs. By 0.32% concentration, all oxygen resources are sent to the brain. Convulsions become borderline seizure as the muscles are now starved of oxygen and have exhausted all their anaerobic metabolites. Major fatigue sets in and the individual becomes unconscious. Soon the brain itself will have no oxygen supplies, at which point it will briefly switch to anaerobic metabolism. Finally, the person dies of brain death within 20 to 30 minutes. So where does carbon monoxide come from and how do you avoid it? Oxygen tends to be less abundant in wood-burning stoves, internal combustion engines, and furnaces with airflow that's blocked. In fact, this is where most people die from carbon monoxide poisoning, because the blocked airflow creates an oxygen-starved environment which produces more carbon monoxide. This is why it's such a big deal to have a working carbon monoxide detector in your home.
Since carbon monoxide is invisible, when should we think about it? Well, right now is prime time as people fire up their furnaces after a very short summer hiatus, especially if their intake or exhaust vents haven't been cleaned thoroughly. Ice fishing shelters are another potential source, especially if the generator or heat source is venting directly into the shelter. And finally, during a natural disaster or a power outage, some people feel that it's a good idea to run a generator or a gas grill in their garage. Of course we all know better, but it still happens. And also, since carbon monoxide fills the entire structure, anytime you respond to a call where there's people with similar symptoms in the same household, it would be something to consider. We've seen it before, and we'll definitely see it again. Let's talk about treatment options. The treatment for carbon monoxide poisoning is oxygen. Lots and lots of oxygen. Since carbon monoxide molecules bind competitively with oxygen on hemoglobin, we can overcome that competitive bind by overwhelming the carbon monoxide with lots and lots of oxygen molecules. At a minimum, this should probably involve a non-rebreather mask, which gets us about 80 to 90% oxygen delivery for most patients. A nasal cannula tops out in the mid-30s in most cases, so if we truly need 100% oxygen delivery, intubation is probably the way to go. For significant carbon monoxide exposures, hyperbaric chambers are the best treatment option, which is why we generally recommend transport directly to Hennepin County Medical Center if the patient's RAD57 reading is over 20% and they are either altered or hemodynamically unstable and carbon monoxide poisoning is the only concern. Hyperbaric chambers, in addition to supplying 100% oxygen, increase the atmospheric pressure of pure oxygen, which condenses more oxygen molecules into a smaller volume. This is much more effective at displacing the carbon monoxide molecules and restoring hemoglobin to its normal state more quickly than other forms of oxygen delivery. Now, some of you have asked about CPAP for carbon monoxide victims. It's a good idea, but CPAP doesn't function the same way that hyperbaric chambers do. CPAP is effective at increasing the force of the air supplied to the victim, but it doesn't condense oxygen molecules the same way that a hyperbaric chamber would. CPAP devices usually have a mask that provides a much better seal than traditional non-rebreather masks, which allows for more efficient delivery of oxygen, but a big problem is that many of the single-use CPAP devices are not capable of delivering 100% oxygen. Check the device that your agency uses before you consider this as a treatment option. The last thing I'd like to mention is that there's been some emphasis recently on the use of SCBA during the overhaul phase of fire suppression, or at least the use of ambient air monitoring. That's fine, but it doesn't help you on a medical call. There are several devices out on the market that clip onto your first in bag that will alarm if the ambient CO level exceeds a safe threshold. Not only would this protect you, but it also might facilitate an urgent intervention for a victim. Might be something for your agency to look into. Let's move on to our next topic. We talked about this briefly back in February when we highlighted a research poster presented at the National Association of EMS Physicians annual meeting in San Diego. Don't remember it? That's okay, we'll refresh your memory. Check this out.
All right, so Dr. Kroll, can you tell us a little bit about yourself and where you're from?
My name's Melissa Kroll. I'm a current fellow at the WashU program in St. Louis. And essentially this is my poster, my research that we've been working on. So essentially it's, can Handgrip Technique affect the volumes provided when doing a bag valve mask? And the background of this is, why did we look into this? What we looked into is, one, we know that the European Resuscitation Council recommends a volume of 500 cc's per breath. And we know from a previous study that we did that adult BVM provides approximately 800 to 1,000 cc's per breath by paramedics. And so in that same study, we found that a pediatric BVM provides a volume of approximately 500 to 600, which is a much more appropriate volume for any patient. And so what we did is we looked at 3 different hand grips. It's a 1 finger, a 2 finger, or a 3 finger, and just to see if that would change the volume. And we looked at the volumes provided in both adult and the pediatric BVM. And what we can see is that, yes, when you change the finger grip, you can affect the volume. These are all statistically significant, but what I tend to think is that these are not really physiologically significant. But you can still see they're about 800 to about 750 cc's of volume per breath, whereas if you look at the pediatric, it's between 500 and 600 cc's per breath. which is again a much more appropriate volume. Our final recommendations are, we would recommend using a pediatric BVM if you're going to do BVM resuscitation, because it gives a more appropriate volume. But if you're going to use an adult BVM, use one finger squeeze, because it's the best. It provides a slightly smaller volume, and that's really what we want to do, is we want to give the right volume to our patients.
To emphasize the point, remember back to your first CPR class when you were taught mouth-to-mouth rescue breathing? No, seriously, it used to be a thing. Anyways, we were taught to give just enough air to see the chest rise. In most adults, that would be between 600 and 800 milliliters. Now, the average volume of a BVM is about 1.5 liters. There's absolutely no reason we should be using 2 hands to squeeze a BVM. One idea that has been proposed is to use a pediatric BVM for an adult patient. Now, this would definitely deliver a more appropriate volume of air, but there are many other variables to consider, such as the volume of air in the mouth, the throat, and the trachea that has to be moved out of the way before the fresh air can reach the lungs. We call this volume of air the dead space. No pun intended. This, in turn, depends on whether or not an advanced airway is in place. For now, we are not changing any of our equipment recommendations, so just be aware of how much volume you are giving your patient. Or better yet, since this is often a task that's delegated to other responders, be aware of how much volume they are giving your patient to make sure we're not overinflating the lungs. The final topic for this month was requested by you. We were asked to talk about medication safety during pregnancy. Now, this is a huge topic, so I'm going to boil it down to 2 areas that are relevant for EMS: pain management and sedation. To be honest though, this is kind of a creepy place to talk about pregnancy, so I'm just going to teleport back to the studio for this one. There, much better. So first, let's make sure we're all familiar with the 3 main stages of pregnancy. This will allow us to understand the effects medications might have on mom and baby. The first trimester is when most of the development happens. The different parts and pieces come together in just the right ways to form a little humanoid. If a medication, a toxin, or a chemical is going to cause harm during this stage of pregnancy, there's a good chance it will result in what we call a birth defect. The most common ones include the heart, the brain, and the skeleton. The second trimester is mainly a period of growth. Harmful effects during this stage will often affect the brain and the overall growth of the baby. The third trimester involves more growth, but now we also get to the stage when the uterus gets a little trigger happy. The main concerns at this stage would be premature labor, growth restriction, and lingering medication effects after delivery. Other factors to consider are that the baby's brain, liver, and kidneys cannot always process medications as fast as an adult's body, so they can experience significant side effects and organ damage from doses that might be normal for an adult. Also, different types of medications cross the placental blood barrier at different rates, so not every medication causes the same types of problems. Let's talk about pain management during pregnancy. Tylenol is the first choice and is safe during all 3 trimesters. Now, that's fine for a slight backache, but might not cut it for a broken ankle. Unfortunately, the only other option for EMS to administer would be an opioid medication, and there are concerns about birth defects related to opioid use in the first trimester. Now, most of this research involves prescription medication, so it's not clear what effects a single dose might have. My advice would be to avoid all opioid medications during the first trimester if at all possible. Second trimester has fewer concerns, and the main problem during the third trimester would be the lingering effects of the opioid medication on the baby's respiratory drive if for some reason delivery were to happen soon after administration of the medication. Now let's talk about sedation. I can think of 2 typical scenarios. One involving behavioral agitation, and the other involving sedation following airway management. Now let's start with ketamine. Ketamine is actually not classified into a pregnancy risk category by the FDA. There are no human studies that have been done to look at the risk to a developing fetus. So etomidate would be the preferred induction agent for RSI if needed. And for excited delirium, if you're unlucky enough to be assigned to an excited delirium call involving a pregnant patient, I would not hesitate to give ketamine in order to limit the risk of harm to the patient and the baby. For less severe agitation, Haldol would still be a reasonable option during pregnancy. Just make sure that you have considered other non-medication options first, so we don't expose mom and baby to something unnecessarily. For maintaining sedation after airway management, things get a little tricky. Benzodiazepines have been shown to cause birth defects, which means Versed should probably not be given unless there are absolutely no other options. This is partly why we treat eclamptic seizures in pregnancy with magnesium sulfate, but the risk of ongoing seizure activity with harm to mom and baby probably outweighs the risks of Versed if you find yourself in such a situation. Now, if you follow our guidelines, and you should, you give magnesium sulfate first, followed by Versed if the seizure does not stop. Now, for sedation after airway management, my preference would be to use fentanyl or another opioid medication rather than Versed, as the risk to the baby will be lower. And remember, once you have intubated someone, it's perfectly okay to go a little bit higher on the opioid doses to maintain sedation. I mean, you're already breathing for them, right? If you have any concerns about medication safety on scene, please contact MRCC for physician advice before you give anything. Okay, now that you're all pregnancy medication experts, let's head back to the Fright Farm to wrap this up.
Well, that was weird, but we did it. Thanks for watching the spooktacular edition of Regions EMS Update. Special thanks to the Ramsey County Sheriff's Department for letting us into the Fright Farm, and to Chief Steve Lucan of the Maplewood Fire Department for setting the whole thing up. Feedback is always appreciated, and you can follow us on social media for future updates. Coming up in the near future, we have a minor guideline update, and for all of you paramedics out there, some information on our credentialing process to ease your mind going into your next critical thinking lab. I promise we won't sneak up on you with any of this information. But speaking of sneaking up on people, I think I'm going to get out of here. I think I've had enough. For all of us at Regions EMS, I'm Dr. Peterson. Stay smart, stay safe, and stay professional. We'll see you next month.